Awesome. So good morning, everybody. My name is Dr. Ari. I'm the newest physician on the team at Coeur d'Alene Healing Arts, and I'm really excited to be bringing you this open forum today. I'm going to be talking all about endometriosis, which is a big passion of mine. I'm going to be doing my best to admit folks from the waiting room as they pop up on the screen still. I just wanted to do some public service announcements before I get started. Y'all are welcome to turn your cameras on if you so wish. No pressure to, though, if you're more comfortable keeping them off. I will ask that everybody has their mute feature on just so there isn't that sort of static background noise as I get talking. But I am presenting this to you from home today, so there may be a little bit of background noise, a baby cry here or there on my end. So just wanted to give you a heads up about that. And I do have a hard stop today of noon, so I'm going to try to finish up my chatting at you a little bit early so that I can answer questions. You're welcome to, if you have an urgent question in the moment that has to do with what I'm talking about, I'm totally comfortable with you interrupting me and having a real life conversation, or you can use the chat feature, but I'll probably not pay too much attention to that as we're going and check that at the end. So if it's a question that can wait, feel free to use that. And as far as using the little raise hand feature, there's, I think, a few too many of you for me to keep tabs on that. So probably best to just jump in and chat at me or use the chat feature. All right, without further ado. So let's talk about endometriosis. I figured it would be good to start out with a little bit of an anatomy review, just because when we're talking about a pathology or a disease that affects the reproductive tract, I thought it could be helpful just to go over what the reproductive tract looks like and what it's doing. So this is a depiction of a uterus right here, a couple of ovaries, and then these are the fallopian tubes with little fingers at the end that are helpful in grabbing an egg that's released from the ovary every month that travels down the fallopian tube and into the uterus. When we're looking at the uterus, this lining right here is actually the endometrium. So this is the lining of the uterus that you're going to hear me talking a lot about further into this presentation. And then this tissue, this thicker tissue outside of the endometrium is called the myometrium. So this is actually the muscle aspect of the uterus. This is what expands during a pregnancy and contracts during a delivery or during the menstrual cycle to help and expel the blood through the vaginal canal, which is down here, this little tip end of the uterus. This is actually the cervix. Well, this is the cervix, I suppose. This is the opening of the cervix where we would collect a pap sample from. So this is what, in a normal menstrual cycle, this endometrial lining on the outside of the uterus, this is actually what builds up in response to estrogen and then sheds and leaves through the vaginal canal every month. So what is endometriosis? Endometriosis is actually just an inflammatory disease that's characterized by the presence and growth of endometrial-like tissue outside of the uterus. So I emphasize endometrial-like tissue because endometriosis actually is not the same tissue as the endometrium, which builds up and breaks down just at the time of the menstrual cycle each month in response to hormonal influence. But endometriosis, which is endometrial-like tissue, does respond similarly to the endometrial lining within the uterus. And the displaced tissue that's outside of the uterus cavity is hormonally sensitive, and it does respond to the hormonal fluctuations throughout the cycle. Similar to the endometrial lining, but the key difference here is that this tissue can respond to those hormonal fluctuations all month long, which explains why some folks with endometriosis have symptoms outside of their menstrual cycle. So it's not just during menstruation, which is the key difference that I want to make. And this phenomenon often leads to really significant pain, inflammation, and sometimes can cause difficulty with fertility, either infertility or subfertility, which I'm going to talk a little bit more about. But these little lesions that you'll see kind of up here on the tubes, this would be considered an endometriotic lesion. These lesions here that you actually see kind of in the myometrium, the muscle of the uterus, is a different disease process that's called adenomyosis that I'm not going to touch on much here, but does cause really similar symptoms to endometriosis. These lesions up here in the tube that look like they may actually be causing a complete tubal blockage, this would be endometriosis because, again, it's outside of the uterus. And then this large cystic structure on the ovary is called an endometrioma. So it's a cyst filled with endometrial-like tissue, or it's sometimes referred to as a chocolate cyst. And this is also a direct product of endometriosis. And then these these little structures are just adhesions that I will speak to a little bit more. They're not endometriosis necessarily, but they are often a product of having inflammation within your pelvic cavity. So what are some of the potential symptoms of endometriosis? The most common symptoms that people think of are definitely having to do with the menstrual cycle or are reproductive in nature. These are things like painful periods, heavy periods, potentially having some pain around your mid-cycle or ovulation. Infertility is something that people do tend to think of with endometriosis, and unfortunately is not an uncommon sort of sequelae or product of having endometriosis. But it can also impact other systems in the body outside of the menstrual cycle, which can lead to some confusion amongst both medical professionals and individuals who are suffering from the disease. Namely, it can impact the GI system. So people with endometriosis can experience things like bloating or changes in their bowel movements. I tend to see more of a propensity for individuals with endo to have more of a constipation picture, but it can also present with diarrhea. There can be pain with bowel movements. It can also impact the urinary tract, and have urinary symptoms like painful urination, or a condition called interstitial cystitis, which is inflammation of the lining of the bladder, can often go hand in hand with endometriosis. And then there can be some more vague symptoms like chronic fatigue or low back pain. Occasionally, chest pain is a combination or is a symptom of endometriosis, and that can be due from when there are these endometriotic lesions that actually adhere or are present on the diaphragm, which impacts what it feels like to breathe and take a breath. So I just point all of this out to say that there's a really wide range of presentations for endometriosis. Not everybody that has endo is going to have all of these symptoms, and some people that have endometriosis aren't going to have any of these symptoms. And one of the things that I always really like to educate my patients on, and that I feel really passionate about, is just spreading the knowledge that the severity of endometriosis is not at all proportional to the severity of symptoms. So that is to say that some folks with really, really severe disease have virtually no symptoms, and some of those individuals don't have any trouble getting pregnant. And some folks with pretty mild disease that maybe only presents as a couple of lesions outside of the pelvis have really, really debilitating pain. And so I always like to just bring that awareness, because one would think that the more symptoms you have, the more severe the pathology or the disease is, and that's really not the case with endometriosis. So what are the impacts of endometriosis on quality of life? This is probably a pretty obvious slide, but just wanted to bring awareness to it. Obviously, chronic pain is a big, big issue. Approximately 1 in 5 individuals with endometriosis develop some sort of mental health disorder or struggle. And research is really clear that individuals with endo are at significantly higher risk for depression and even suicidal ideation. There was a really substantial survey in, I think it was 2020 or 2019, that looked at a significant number of individuals. I think something around the ballpark of like 15,000 people were surveyed who have known endometriosis. And of those 15,000 people, 50% of individuals reported experiencing suicidal ideation at some point during the course of during the course of their life and their experience with endo. And the magnitude of mental health illness is likely due both to living with chronic pain and also being dismissed by healthcare providers, friends, family members, and not having your pain taken seriously. And then, of course, fertility or infertility is a really big impact on quality of life for individuals who do desire pregnancy. No, my slide is stuck. Sorry about this. All right. So causes and risk factors of endo. We being the greater medical community and researchers, are continually learning about endometriosis and where it comes from, what causes it to continue growing. Genetics definitely play a part. We know that endometriosis is often hereditary, meaning that if someone in your family has a history of the disease, you are more likely to have it. But not everybody who has endometriosis has a family history, and not everybody with a family history of endometriosis is going to develop the disease. So researchers are just continually exploring specific genes or genetic mutations that predispose somebody to experience endometriosis throughout their life. One of the early theories of endometriosis looks at embryology and how potentially these endometrial-like cells are actually spreading or propagating early in utero when the early sort of blastocyst cells are differentiating and starting to become a little fetus. So that is one of the theories that people are looking at. Hormones definitely play a part, specifically the estrogen-progesterone balance or ratio. So estrogen is the hormone that's dominant in the first half of the cycle, which we call the luteal or the follicular phase of the menstrual cycle. And then progesterone is dominant after ovulation, before menstruation occurs. And we do know that endometriosis is an estrogen-dependent disease, meaning that it responds to estrogen. So you'll often hear providers talk about this estrogen dominant state, which doesn't necessarily mean that you have sort of abnormally high estrogen levels. It can, but it can also mean that the ratio of your estrogen and your progesterone, or the hormones in your follicular phase and your luteal phase, are slightly out of balance. And more, we're talking about endometriosis, not so much as an estrogen dominant state, but as a progesterone resistant state. And this is likely due to this suppression of certain progesterone receptors and how they act within the endometrial lining and also the endometrial implants outside of the uterus. And then anatomical structure and function is definitely something that is talked about when we're talking about causes and risk factors of endo. I think the first theory that I know of about where endometriosis came from was actually called the Sampson's theory. It came out, or was starting to be advertised, in like the early 1920s. And it looked at the notion of retrograde menstruation, which is a phenomenon that happens in quite a few women, where during the normal menstrual cycle, when the lining of the uterus kind of sheds and leaves, the blood leaves the body through the vagina, some of that blood actually goes up backwards through the fallopian tubes and then can lead into the peritoneal cavity outside of the uterus. And the early theory was that potentially this was how this endometrial-like tissue was getting outside of the uterus and into the greater pelvic structure, and that the blood was adhering to the different organs. This has since been disproved on a number of occasions, just because we've looked more closely at the endometriotic tissue, and there's enough differences between these endometriotic lesions and the lining of the uterus that we can say they're not exactly the same. But you will still hear this theory of retrograde menstruation be talked about amongst certain providers. And then immune system dysfunction is a big one, and it's one that I feel really passionate about, namely looking at the microbial balance or imbalance of the endometrial lining. So we often talk about or often when we talk about the microbiome, I think we think of the gut, but it turns out the endometrial lining and a lot of other structures in the body also have their own microbiome. So we're starting to call this phenomenon the endometriobiome. And research is suggesting that the microdiversity of the endometrial lining in women with endometriosis may have an altered bacterial composition compared to women without endo. And there are a couple of specific bacteria that have come into question. And this is likely significant because of the inflammatory response that it creates, where this imbalance may contribute to chronic inflammation. And these certain microbial species that are more abundant or are present in people with endometriosis could trigger or exacerbate the inflammatory response that's associated with the condition. And then this has big implications in terms of how the immune system is working or not working, where the immune system maybe fails to adequately recognize and respond to the endometrial-like tissue that's outside of the uterus. So that allows it to continue to grow and progress. And then there's always some sort of hormonal influence or relationship between microbial balance and hormones. And this dysbiosis or, imbalance of bacteria within the endometrial lining could potentially affect hormone metabolism or signaling pathways, which is how chemicals in our immune system work to communicate. And that can also impact the growth and the spread of endometriosis. So looking at the relationship of the microbiome in the endometrial lining and the immune system is really exciting because it offers some potential new diagnostic potential where we may in the future have the option, and we're actually already starting to do this, to analyze the endometriobiome similarly to how we would analyze the gut microbiome. And that can kind of provide novel insights into how to diagnose endometriosis, as opposed to some of the current gold standards for diagnosis, which I'm going to get into in a bit here. And then, of course, ultimately, we care about this because of the therapeutic implications and how this means we can go about treating endometriosis. So understanding the role of the endometriobiome and endometriosis gives us new therapeutic strategies where we can start talking about things like rebalancing the lining, the microbiome of the uterine lining with things like probiotics or prebiotics or certain microbiome modulating medications. And so this is just a big area of research that's growing in the world of endometriosis. So diagnosing endometriosis definitely poses some challenges. A huge one is obviously just this lack of awareness amongst both the general public and healthcare providers. And ultimately, this can lead to pretty significant diagnostic delays. And like we already spoke about, endometriosis can present with really nonspecific symptoms. So if somebody has a primary complaint of constipation and painful bowel movements, it may cause their healthcare provider to kind of hone in on and go down this path of looking at the gut or referring to a gastroenterologist. And when we get outside of the sort of standard reproductive system and are bringing in specialists who don't have expertise in endometriosis, it can really delay how long somebody goes without having a diagnosis. Not to mention, even when individuals have complaints of painful periods, heavy periods, pain with sex, painful ovulation, these things can be blown off as normal. I can't tell you how many patients I see who come in with really significant pain who I suspect may be dealing with endometriosis. And they tell me that they've talked to their providers about this before and that everybody has told them that their pain is normal. And then there's definitely some imaging limitations when it comes to diagnosing endometriosis. That is a big challenge and again leads to some diagnostic delays. When we compare the diagnosis of endometriosis to other sort of pelvic or abdominal pathologies where something like a CT scan or an MRI or even an ultrasound might be definitive, meaning that we can take an image and say, yes, this disease is present or this disease isn't present. It's not so simple with endometriosis. And that's likely because the tissue itself so closely resembles the tissue of the uterine lining that it's absent often on ultrasound, which tends to be the imaging, the first line of imaging that individuals will use. And I'm going to talk all about more of this in depth here on the next slide. So those are the challenges, but how do we actually get a diagnosis of endometriosis? So a medical history and physical exam are absolutely the first step. So taking a thorough medical history, discussion of symptoms, asking patients about their pelvic pain, about their menstrual history, about any history of infertility or pain with sex. These questions are really essential in evaluating the likelihood that a patient is dealing with this condition. And then a pelvic exam is a really important tool as well, even if we're not using it to collect a pap smear. I use a pelvic exam for a number of reasons. One of them is just simply to evaluate the degree of pain with a pelvic exam, because similar to having pain with sex, individuals with endometriosis often do experience pain with pelvic exams. So that's one of the reasons that I will perform them, is simply just to get a gauge on what that pain level is, knowing that pain is a very subjective experience, but it's a starting place. And then when the disease is rather progressed, you can occasionally feel small endometriotic lesions on a pelvic exam. So doing a pelvic exam is always a really important first step after taking a patient, having a thorough conversation with the patient. And then imaging studies tend to be the next line. Usually the imaging study that's ordered first is an ultrasound, specifically a transvaginal ultrasound, which is when the ultrasound probe is inserted vaginally to take a look at the uterus and the ovaries. Really, the only way to diagnose endometriosis, and it's not even a definitive diagnosis, but the only way to get close to diagnosing endometriosis with an ultrasound is if endometriosis has impacted your ovary to the point that you have an endometrioma, which is that cyst that I pointed out early in the lecture, that big chocolate cyst, blood-filled cyst on the ovary. That structure can be visualized on ultrasound. But even still, you can't say for sure, or a radiologist can't say for sure that it's endometriosis. The only way to know for sure is to actually then take a biopsy of that mass on the ovary. But an ultrasound that has a mass that appears like an endometrioma on ultrasound is very, very suggestive that the disease is present. And generally, those who have endometriomas have pretty extensive disease. And I'm not even really getting into talking about the staging of endometriosis in this lecture, just because there's a lot of different opinions on it and it's always changing. But if you have an endometrioma and it's found on ultrasound, you likely have pretty extensive disease. MRIs are also used occasionally. MRIs or magnetic resonance imaging are more extensive imaging that can look at smaller lesions that are potentially like hiding behind structures. It's not a form of imaging that I have a lot of experience with ordering or interpreting, so I'm not going to get into it too heavily, but just wanted to point out that sometimes providers with more experience with that specific type of imaging will order it as a part of their diagnostic workup. But the important thing about both an ultrasound and an MRI when it comes to looking for endometriosis is if you have either of these images and they come up completely negative, meaning nothing is found by the radiologist that appears to be endometriosis, it does not mean you don't have endometriosis. And I really can't emphasize that enough. So then the next step is often a diagnostic laparoscopy. So this means that you are volunteering to go in for surgery, obviously under the recommendation of a physician and a surgeon, to do an exploratory surgery to look and see if you have endometriosis. The procedure is laparoscopic, so it means there aren't any big incisions. They tend to go in through your belly button and occasionally a couple other really small incisions low down on your pelvis. They blow your belly up with air and they look outside of your uterus, again, because this isn't a uterus problem. for these small lesions. And I meant to include some images in this presentation of how endometriosis actually appears in a surgery, but I forgot to, but you can definitely Google that if you're interested. There's plenty of images online. It's worth doing just because it doesn't appear, in my opinion, to look as extensive as one would think. These lesions can often be really tiny. They can blend in with the surrounding tissue. It really does take a very experienced surgeon to be able to identify the endometriosis, because sometimes it appears dark purple in color. Sometimes it appears kind of pinky and flesh colored. Sometimes it can appear kind of more white and opaque. And so it's really important, if you're going to move forward with a diagnostic surgery, to make sure that you have a surgeon who's not just, an obstetric and gynecological surgeon, but somebody who's very experienced with endometriosis. And then I just made note of excision versus ablation, because there are different types of endometriosis surgeries. Excision, like it sounds like, is actually when the surgeon goes in and really excises and cuts out the endometriotic tissue. Ablation is a slightly more superficial procedure. There's different instruments that are used to sort of ablate or scrape off or try to eradicate the lesions through different methodology that's not cutting them out. Excision tends to be a more extensive surgery with longer recovery times. And there's really pros and cons to both of them. And I'm not going to get too heavily into that because I'm not a surgeon, but all of that to say that it is important to do your own research and talk to your providers and make sure that you're choosing the surgery that's best for you if you're deciding to go the surgical route. And then biomarkers are blood tests that are definitely tend to be indicative of underlying diseases. And there aren't specific blood tests or biomarkers that are currently available to definitively diagnose endometriosis. But research is pretty ongoing in this arena to find biomarkers that may be able to aid in the diagnosis or at least monitor the disease activity. There is a biomarker already. It's called CA-125. It's actually an ovarian cancer marker that some providers are using to aid in the diagnosis of endometriosis, or to at least track the progress of the disease. Again, it's relatively nonspecific because it's elevated in other conditions like ovarian cancer. It's also elevated in people who don't have cancer or don't have endometriosis. I'm not using this in my practice, but I do know of some providers that are using it and finding it helpful. But hopefully over time, we're going to be able to uncover some more specific biomarkers that will make the diagnosis of endo much easier and much less invasive. So fertility and endometriosis, I wanted to bring some specific awareness to the struggles of fertility that can be the product of having this disease in your pelvis. Part of it is, I think there's there can be some confusion about why endometriosis causes infertility or subfertility, just given the fact that it's not necessarily a uterus problem when we're looking at the lining of the uterus. I'll talk a little bit more about that because it's a bit more nuanced. But it's actually a pretty complex phenomenon, and all of it really comes down to this inflammation or this inflammatory process. So you're going to hear me say that over and over again. But endometriosis does have the ability to distort the pelvic anatomy. So it can cause adhesions, which were those little like ropey structures that I pointed out early in the presentation. It can cause scarring and tissue growth in the pelvic cavity. And this can either block the tubes, as I pointed out, and prevent the egg from getting into the uterus and even becoming fertilized. Or it could pull an ovary kind of to the side so that the fallopian tube isn't able to reach up and grab the egg. So all of this to say that having endometriosis can structurally distort the pelvic anatomy and can impact fertility in that way. It does also impair the physical process of ovulation because of the inflammatory and hormonal imbalances that, lead to the development of the follicle and the release of the egg. And there is some research that shows that it can actually reduce the egg quality, likely again because of the inflammatory process that's present within the disease pathology. And the chronic inflammation leads to oxidative stress. And these are all buzzwords, but ultimately egg quality can be decreased because of the inflammation. And then let's talk a little bit about the altered uterine environment. It's not so much that there's something wrong with the uterus, but the uterine lining or the endometrium can be impacted and not allow for proper implantation because of these hormonal disturbances that are occurring at the level of the lining. One of the ways I often describe it to patients is actually that endometriosis can create like an inhospitable environment for an embryo to implant. And it can, just impact either the embryo's ability to survive or once it implants to continue to grow and thrive. And then one of the things that I think I don't see talked about enough is that because, again, of the inflammation and the inhospitable environment that endometriosis creates because of inflammation, it can impact a sperm's ability to survive. So just some like basic reproductive lesson. An egg can live for roughly 24 hours once it's been ovulated. Sperm live anywhere from 3 to 7 days. And so it's not always just about the egg. When we're talking about conception, the sperm's ability to survive in the uterine environment, it has really big implications on whether or not fertilization occurs. And sperm oftentimes aren't able to survive within the uterine cavity because of the inflammation that's present with endometriosis. And then I just note the increased risk of miscarriage, because even if conception occurs and even if implantation occurs at the optimal time, there is an increased risk of miscarriage in individuals with endometriosis. Likely, again, due to the inflammation and hormonal abnormalities and the uterine changes that increase the likelihood of pregnancy loss, especially early in the stages of pregnancy. And I just always like to, tell the flip side of the story, which is that it is absolutely possible to have endometriosis and to get pregnant without any struggle. And even if you have it and you do struggle, it doesn't mean that it can't happen. So what are the conventional treatment options for treating endometriosis? Most of the time, if you go to just like your normal primary care doctor or OB-GYN, and they, suspect that you might have this condition, pain medications are kind of first line, whether that's an NSAID, like an over-the-counter medication, ibuprofen, acetaminophen, Aleve, Tylenol, these sorts of things. Occasionally, in really severe cases where the over-the-counter medications have failed to provide adequate pain relief, some of these providers will bring out some of the heavy-duty hitting pain medications. But long-term use of these medications, for obvious reasons, are pretty strongly discouraged. Hormonal therapy is often also used, things like birth control pills or IUDs, which are progestin-only contraceptives, because again, they kind of balance out that estrogen-dominant, estrogen-dependent state. And they can suppress menstruation, which really reduces pain, but it does also reduce the growth of the disease. We can get into some fancier hormone therapies like GnRH agonists that are medications that work by suppressing the production of estrogen. Ultimately, they kind of introduce like a temporary menopause-like state to reduce the symptoms. I'm not going to get too heavy into those because they're not things that I use in my practice. And then surgical interventions, of course, which we've already talked about, those laparoscopic procedures that are both diagnostic and curative. I'll use that word lightly, but all I mean by that is that the surgeons can go in, they can do an exploratory surgery. If it's there and they see it, generally in that same surgery, if you've chatted with them about it beforehand, they can also take action and do their best to remove the tissue. And this does tend to cause improvement in symptoms. It does tend to improve fertility outcomes just because you're changing the hormonal environment, you're changing the inflammatory response of your greater reproductive system. But oftentimes it's important to then use other treatment modalities once you've had surgery to try and prevent the endometriosis from reoccurring at all or as quickly. And then I wrote down hysterectomy as a last resort. Sometimes individuals with endometriosis will get the uterus removed. But it's important to note that that doesn't always completely eradicate the symptoms, because even if you're not having a menstrual cycle, again, these endometriotic lesions are often outside of the uterus. And like I already mentioned, can respond to hormonal fluctuations throughout the entire month, not just during menstruation. And assuming that your ovaries are left behind and you're still having all of this hormonal input and stimulus, the lesions that are still present can still cause symptoms. So what's my approach to endometriosis? This is going to be very kind of high level summary, just because it's obviously very nuanced and individualized based on what other factors the patient that I'm working with has going on. And my approach really does depend and vary significantly depending on a patient's desire for fertility and their timeline for fertility. One of the things that I feel the most passionate about in my endometriosis care is establishing a really good care team for my patients. So I always really like to be able to refer to a trusted OB/GYN colleague who has specific endometriosis training, just so that they have somebody on their team if or when a surgery becomes necessary. It's so much easier to have somebody in your back pocket and to have that relationship before you need it. I also really love to get my patients connected with acupuncture, somebody that does body work, like myoabdominal massage is really great. I love it if the folks that I'm referring to for either of those modalities also have training in Chinese herbalism, just because I find Chinese herbs to be hugely beneficial in treating any number of reproductive pathologies. And then another physical modality that I really like to get my endo patients established with is pelvic floor therapy, again, just to sort of work on the structure of the pelvic cavity, and to help improve its general function and also just quality of life from a pain perspective. I also work a lot with diet and nutrition. My two main goals with diet and nutrition are to reduce inflammation and to optimize gut health. Obviously, inflammation is a very vague descriptive word, but my sort of general approach to that is to start by removing sort of the big inflammatory offenders in the diet. And as much as I hate to have patients completely cut out massive food groups, I do see gluten and dairy being really inflammatory for a lot of patients, even without endo, but specifically for those with endo. And then when I'm talking about gut health, I find it's pretty imperative to work on repairing the gut in people with endometriosis, specifically from an immune system perspective. So roughly 75% of our immune system lives within our digestive tract. And so having that be optimized is really, really important when we're talking about immune system, even outside of the gut. And the wall of your intestines is supposed to just be a little bit permeable so that the nutrients that you're getting from your food can pass into your bloodstream and sort of sustain you. But when that wall becomes leakier than it should, whether you're eating because you're eating inflammatory foods or you have other sort of systemic inflammatory conditions going on, things other than nutrients start getting through, whether that's food particles or bacteria or viruses or other toxins. And when these get through, it can cause your immune system to get activated and it can cause greater inflammation. So because I often see this systemic inflammation in my patients with endometriosis, which may present as constipation or diarrhea or leaky gut or rectal pain, I find that reducing the bowel inflammation and working on gut healing can really be helpful in reducing the pain that's associated with endometriosis and just generally lowering systemic inflammation. Stress management is an obvious one, but it's really super important from my perspective. It's really crucial at preventing symptom exacerbation and promoting overall well-being. To do this, I like to use techniques like deep breathing exercises or mindfulness or meditation. Regular physical exercise is a really big one. It's important to do it well because it can also increase stress in certain cases. And then social support is really critical, whether that's just friends and family or actually getting somebody connected with a counselor. I definitely work with hormonal balance. This tends to be where I'll get labs involved and maybe order some labs to look more heavily at that sort of estrogen progesterone balance. I tend to rely pretty heavily on botanicals or herbal medicine to support this balance, whether I'm using herbs that kind of help the body process high levels of estrogen, or I'm using herbs that are progestogenic or act like progesterone in the body if I suspect that the issue is more of a progesterone resistance than an estrogen dominance. I also use labs sometimes when we're looking more at gut health if I really suspect that might be the root cause of symptoms. And then detoxification support is also something I'm really passionate about and ties into the hormonal balance. So xenoestrogens are something that you'll, hear about from time to time. They're man-made chemicals from the environment that really can contribute to these symptoms of estrogen dominance. Common sources of xenoestrogens are things like pollution or non-organic meats and dairies that are commercially raised, BPA that's found in a lot of like plastic water bottles. Dryer sheets are a big one, fabric softeners, air fresheners that have artificial fragrances, soaps, detergents, things like that. And so these can really interfere with your sort of natural hormonal balance. And I find that it's really important to just help the body rid itself of these chemicals. So I'm always talking to patients about removing these sorts of offenders, and we call them endocrine disruptors from their life in obvious ways, like changing up their dryer sheets or not using dryer sheets at all, or changing up what products we're putting on our body. I'll just put in a quick plug for the Environmental Working Group, which is an amazing database. It has a specific branch that's called Skin Deep that can be used to look at not only these xenoestrogens, but other endocrine disruptors that are within products. And the database has thousands and thousands and thousands of products that we all have in our homes, and it ranks them on a scale of 0 to 10, 10 being the most disruptive and 0 being the cleanest. I like my patients to make sure that everything that they're coming into contact with on a regular basis, ideally is like under a 3. And one of the ways that I help support the body in ridding of these toxins when it's hard to stay away from them in this world that we live in is really just through supporting the liver and making sure that the body's efficient at detoxing the hormones and xenoestrogens. So I can do this through things like nutritional support or dry skin brushing, saunas. Certain botanical medicines are really good at helping the liver to process these estrogens. And then sometimes I'll even use something like fasting just to give the whole system a break. And I'm not going to talk too heavily about the future perspectives in research, but I just put this on there because endometriosis, like all areas of women's health, there's something that is continuing to grow and finally getting more of the attention and funding that it deserves. And it's all really exciting in terms of the potential for more easily being able to diagnose this condition and having some more treatment options that are available to us. So I'm going to kind of wrap up my spiel there and leave this open to anybody who has any questions. And if you don't have questions, that is okay too. I'll check the chat. I didn't think I saw anything come in. Give everybody a couple seconds to see if there's any questions that are coming up. Otherwise, we can just go ahead and wrap this up. And I do really hope that this proved valuable and informative in some way.
I have a quick question.
Yeah.
Can you talk more about how the endometrial biome is tested?
That's a good question. And it's one of it's that I shared that more because it's a perspective. It's something that we're researching as a potential way to treat endometriosis and to look at the biome. to my knowledge, the way that they're talking about doing that now is actually through collecting a sample of menstrual blood, just to see, because when when you bleed every month, you're shedding your endometrial lining. And so the research that I have read, that's how they're doing it currently. I don't know if, if and when this becomes an actual diagnostic opportunity, if that's how we'll be doing it, but similar to a stool sample now, where you actually are collecting stool to look at your GI microbiome, to my knowledge, we're actually looking at menstrual blood currently.
Is that something your office does then?
It's not, because it's not actually something that's I don't think anybody's doing. I believe that this is all happening in sort of prospective studies at this time. But it is something that I feel really excited about, and I'm kind of keeping my eyes on, as far as, as these things become more available to just general practitioners.
Yeah, that's amazing.
Good questions. Anybody have anything else for me before I stop recording and get this uploaded? This will be uploaded to the website, so if you wanted to peek back on it or reference anything that I said, that should be available to you. All right, everybody. Well, thank you for tuning in live, and I hope everybody has a good rest of their day.
Thank you, you too.
Yeah, bye, everyone.